to see how we could be helpful, how we could provide policy options to policymakers and information that might help them in responding to the epidemic. I want to talk a little bit today about some of the research that we've done and some of the ideas that we've had. And I want to start by thanking our crackerjack team of research assistants, Wagner students, collaborators, and funding agencies that have helped us do this work. So let me begin. What I want to talk about today is 3 policy issues that have come up in thinking about the health policy impacts of the COVID epidemic. A couple of economic insights that will be a little familiar to those of you who've taken my health economics course or are taking it now. A shout out to a kind of unsung hero of public administration and public policy, and a novel empirical finding that Mitchell Moss and I, with a group of collaborators, have been working on that I think you'll find interesting. So let me launch right in and talk a little bit about how to think about COVID-19 in terms of healthcare policy. We have a paper coming out in JAMA looking at what COVID is likely to do to the healthcare share of GDP and how we might think about that. This picture is not in that paper, but it will give you an idea of the kind of thing we're thinking about. The best estimates of the cost of COVID suggest that in 2020, the COVID epidemic will raise the share of healthcare in the US GDP more than probably 10 years of healthcare spending would be likely to do. So a very, very big impact in terms of healthcare policy, healthcare spending. Where does that show up? It really shows up in people getting care. And one of the big policy issues that I think struck people right at the very beginning of the epidemic and continues to this day is how we can make sure that people have financial access to the healthcare that they need. This is some analysis that we've been doing. We've built a little simulator that you can hopefully be able to access by Friday or so, looking at how the costs and cases of people with COVID will be distributed among different kinds of insurance status. Because of course, in the US multi-payer healthcare system, different people are gonna have different kinds of healthcare status. And you can see here that there will be a chunk of people who are uninsured, the bulk of people and who are hospitalized, who have outpatient visits and so on, will be privately insured, and then there's a section who are Medicare and Medicaid covered. To give you a sense of what this means, the Kaiser Family Foundation estimates that the average out-of-pocket cost per person hospitalized with COVID-19 will be around $1,300. That's an average. There are a lot of people who will have costs much higher than that. And what is particularly vexing, I think, in this context is that because it is a contagious illness, it's quite likely that several people in the same family will incur costs at the same time. And so the cost of treating COVID for families who have private insurance could nonetheless be very substantial. I think another thing that we know about the cost of COVID and the cost of caring for people with COVID is that it's going to vary around the country. And particularly our simulator lets us look at how it will vary by state. And you can see here a comparison between New York and Texas. The really 2 things that are really dramatic here. One is Texas did not expand Medicaid. And so there are far more people who are uninsured in Texas who will be requiring care for COVID relative to in New York. And the share of people on Medicaid will be smaller. So we've been talking to federal policymakers to think about how one could respond to these various dimensions of giving people financial access to COVID care. And I want to distinguish between the testing piece of this, where I think there's been a pretty aggressive public health response to set up testing sites, and very early on Congress passed legislation to make testing available to people at low cost, and then the more complex problem of how to pay for the treatment costs. And here I think there are really 3 kinds of questions that we need to think about. One is how to cover the cost of treatment for people who are uninsured, and then for people who have private insurance or even Medicare, how to cover the cost of co-payments and how to cover out-of-network costs. Now, the first problem, the uninsured, would seem in some respects to have been the easiest one to deal with. We have actually dealt with this kind of problem in the past. There is a process by which states can pretty quickly ask the federal government to amend their Medicaid programs to enroll people following new, much more lenient rules. In New York City, in post 9/11, because the Medicaid Enrollment Office was actually in the World Trade Center, they actually revised Medicaid very quickly, created a program called Disaster Relief Medicaid, in which people could self-attest that their incomes were low and that they didn't have coverage, and you could enroll them in health insurance very quickly. So that mechanism exists in the federal government. And as well, since Obamacare passed and we have these Affordable Care Act marketplaces in all the states had the option of creating special enrollment periods to allow people with higher incomes to enroll directly into those marketplaces. And New York has done that, and New York also expanded Medicaid. So as you saw in the previous diagram, the problem of uninsured people needing coronavirus care is not a very big problem. It remains a problem, but it is not a very big problem in New York relative to other states. Unfortunately, this is not the direction the federal government chose to go in responding to the problems of uninsured people who are afflicted with coronavirus. Instead, the government has decided to take some of the money in the recently passed CARES Act, which is legislation to provide money to the healthcare system for people affected by coronavirus, and use that money to pay for the costs of uninsured people seen in the hospital. So they'll be paid at Medicare rates for the care that they receive in the hospital. Some people think that this is a step in the direction of Medicare for all. I don't think that's the reality here. It's a way essentially of not forcing the states to expand Medicaid in any way in the context of the coronavirus epidemic. So you might think that in the absence of paying the hospitals directly, the states would think about actually covering uninsured people and giving them actual health insurance. This is really a very deliberate stopgap measure so that that doesn't need to happen. Of course, it is not nearly as good for uninsured people to have hospitals paid for their coverage rather than to have coverage. The distinction is, for example, that if you show up with a heart attack, believing that you might have coronavirus, and you're uninsured, you're still going to get charged for that visit. And your physician is not going to be paid because the CARES Act coverage only is for the hospital. So this is a very limited stopgap kind of measure. It also has the effect of really channeling money to places that didn't expand Medicaid at the expense of places that did. Second dimension of this problem is to deal with these co-payments that could be quite high and out-of-network costs, which could also be high because people may not be getting the care they need for COVID-19 from hospitals that are inside their network. So far, all that's really happened on that front is voluntary agreements with various insurance companies to reduce co-payments and to protect people from out-of-network bills. The problem with this is that most people who have private insurance don't actually get their insurance from an insurance company. They get it from their employer, who is self-insured, and these agreements are not going to be universal to all of those employers. It would be really hard to do that through a set of voluntary agreements. So there's still a lot of holes in the effort to try and provide financial access. These costs for private insurance programs could be quite substantial. These are estimates based on data from Fair Health and from Cover California that suggest that premiums next year might go up 40% in private insurance to cover the costs of COVID care. You can see here that for Medicare and Medicaid, the costs are somewhat lower. And the reason for that is that the baseline, well, looking at Medicare first, Medicare pays much, much less than private insurance does per COVID case. But Medicare baseline expenditures are much, much higher than private expenditures. The reason for that is that the Medicare population is older and sicker. So relative to the baseline expenditure, Medicare costs are not going to increase as much. As to Medicaid, also, their costs for COVID care are relatively lower. On top of that, the Medicaid population hasn't been, which is very, very heavily children and younger adults, hasn't been as much affected by COVID. So much of the effect is expected to fall on private insurance. So the question is what to do about this, how to provide people with protection against co-payments, out-of-network care, and to do it in a way that preserves the health insurance system so people actually have coverage. With Kathy Swartz, we published a blog, it seems like 100 years ago, 2 weeks ago, calling for a federal reinsurance program based on having co-payments reduced to zero and out-of-network costs covered at median allowed amounts. It's actually an idea that's being talked about, so we'll see whether that happens. Right now, there hasn't been any real policy action on this front. The second big policy problem that has affected us is the kind of bifurcated nature of the change in the demand for healthcare services. Here I'm showing employment in two parts of the healthcare system: hospitals, which you can see has been rising pretty steadily, and dental offices, which you can see dropped off extremely sharply in March. And dental offices are just one of the kinds of healthcare providers that have seen a real drying up of demand. So what do we see here? We see actually two different kinds of responses for providers. On the one hand, hospitals being just swamped with a need to buy personal protective equipment, ventilators, ICU beds, to hire nursing staff. There's some evidence that nursing payment rates have gone up a lot to try and get more people back into the nursing market, to pay additional professionals. And on the other hand, we see reduced demand for dentists, for primary care practices, elective surgeries that have been delayed, mental health providers, all kinds of people who are facing reduced demand. Some of that demand may come back when we move out of shelter in place, when the virus, if and when we get into a better situation. So we don't know how long that will last for, but some of this is certainly not going to come back. There are certainly some amounts of demand that have just passed and are not going to happen. So the CARES Act is supposed to take care of both sides of this to some extent, but there really hasn't been much work thinking through how that funding needs to be targeted. For example, we've been looking at how to target funding to mental health providers, to those who are providing care to the most seriously mentally ill, and whether it should be done based on how many coronavirus cases there are in an area, or conversely, whether the area is in shelter-in-place mode, whether we think that the care will be provided later, or whether it's going to be put off forever. So there are a bunch of policy issues around targeting, even when the federal funding is available. A third set of issues is that at the same time as the epidemic has hit the healthcare system, it's also caused a tremendous economic downturn, and a lot of people are losing their health insurance. So the question is what to do about them. And just to lay out the sort of options that are available, really in the past, the main option that's been available is Medicaid, but now we have two kinds of policy options that Congress is considering that I think are worth thinking about. One is whether people who lose their coverage, their job-based coverage because of the economic downturn, should be allowed and encouraged to join the ACA marketplaces. That's now available in New York, but the federal government hasn't opened the ACA marketplaces in a special way. Most people are still eligible if they've lost their jobs, but it's going to be more complicated. The second option is there is a system called COBRA, which allows you to keep your employer-based health insurance by paying the premium. We could provide subsidies for people to stay in that coverage. It's a little bit more expensive than moving them into the marketplaces. That's a policy option that would make sense if we thought people were going to be returning to the same employer. So we don't want them to have to change their network of coverage or things like that. But it doesn't make that much sense if you think this is a long-term change in employment. Then we'd be better off moving them into the marketplaces. So that's another area where we've been talking to federal policymakers about how to think about this short-term, long-term trade-off and what the best way to do policy here is. So let me turn from that to a couple of broader economic ideas that maybe will be familiar to some of you in the class, and that help us to think about how we might deal with COVID-19 from a policy perspective in the longer run. So the first question is, what is the economic cost of this terrible pandemic? How do we think about that? So conventionally, when we look at healthcare as a share of GDP, for example, we are really looking at the economic cost of a disease as being primarily what we might call the direct cost of the illness, the cost of the medical treatment that is associated with cases. Right now, that cost is the cost of, for example, putting people in an ICU. It could become a cost of treating people with new medications or other things that have to do with the actual treatment of the cases. On top of that, a lot of health economics research has looked at another aspect of cost, which is the value of the lives that are lost due to the disease. In some of your classes, you may have learned about cost-benefit analysis and so on. And actually, early on in the epidemic, there were a bunch of people trying to make these calculations, which I think were quite wrong-headed, trying to figure out what is the value of the lives that are lost due to the disease in economic terms, a pretty morbid way to think about things, but it is a kind of calculation the government does. So that's a second dimension of the costs of the epidemic. A third dimension is the economic cost, the dislocation because of the shelter-in-place shutdown of the economy. That's a much, much bigger number at this moment. We've really stalled out the whole global economy. And that can be reasonably attributed to COVID-19. And then finally, I think beyond the sheer economic dislocation, we are all experiencing a tremendous deterioration in the quality of our lives as we take precautions across the board. So all of these different elements are all associated with the economic cost of COVID. This actually is a really interesting way of thinking about the problem, and I think I'm just going to walk you through this slide. It's not mine. on the horizontal axis, we have the severity of a disease. In the case of COVID, this is quite a severe disease. And on the vertical axis, we have the costs of the disease. And you can see that the bottom upside down U-shaped curve, which is labeled epidemiologic costs. What that says is, what is the cost of the disease? It is increasing in the number of people who actually have the disease, but as the disease becomes more severe, the epidemiologic costs decline. We're seeing that exactly happening here in COVID. What we're seeing is that the number of cases is not reaching the numbers that the early modelers had anticipated because people are locking down. The disease is not spreading as quickly as it would. But you can see the top line, which shows total economic costs. The reason that epidemiologic costs are low is because the total economic costs are enormous. These costs of being locked down are very, very large. And what that tells us is that the value of coming up with ways of stopping the epidemic, either through immunizations or better treatment or herd immunity or more rapid testing, all of those things, there is tremendous value in it that is not captured exclusively by the medical costs of treatment or even the lives lost to the disease. It's actually captured by the fact that you are all sitting in your apartments watching me on Zoom instead of being at PUC listening to me in the Rudin Forum. That is the huge economic cost of the disease. And we can think about that in terms of other diseases as well, but it is so obvious here. A second big economic insight that comes from similar kind of modeling has to do with this question about what this whole argument that we're hearing now between the president and the governor and the mayor about who's going to make the decision and when are we going to go back to work and when is the shelter in place story going to end. And certainly there are some people whose decisions will be very much determined by what the governor and the mayor decide because their jobs will go back online, especially city jobs, and they will have to go back to work. But for others, whether they go back to work or not is going to really depend on an assessment, a trade-off that they themselves are going to make. And that trade-off is going to have to do with what they perceive to be how safe they're likely to be. And what's really interesting here is that we can actually see this in the run-up to the epidemic, and we will see the same thing even in much more strength as we move towards, I hope, soon the end of it. So I actually want to show you what I mean by this. What I'm showing you here are, I think, some of the coolest data that we have. This is the New York City syndromic surveillance system. It's been in place since middle of the Bloomberg administration. And the red line here is March the 17th, which is the first day that the city went into shelter in place. You can see here that around the 7th or 8th of March, if you look on the graph, on the picture, I don't know if I can make you see it. I don't think I can do a pointer. But if you look at the March 7th or 8th, just a little bit to the left of that red line, you can see the sudden uptick in visits for respiratory counts and in influenza-like illness visits. You can sort of see here the decline in flu in the bottom picture. You see that flu is happening and then it starts to fall. And then all of a sudden there's this strange, unanticipated increase in flu, which turns out afterwards to be coronavirus. So it starts to happen around the 7th of March. Honestly, before the 7th of March, nobody in New York could plausibly have believed that anything was happening. You really don't see much action here. But on the 7th of March, Farzad Mostashari, who is an unbelievably brilliant epidemiologist, physician, public servant, now an entrepreneur, said, wait a minute, I'm looking at the ILI data, and there's a clear sign of increasing influenza-like illness in New York. That's really weird. What is going on? We need to find out the answer. This is the moment we need to think about intervention. So syndromic surveillance, a great public health and public policy, public management tool, really important here. But we can use the same tool to think about how people have responded to the epidemic. So again, remember that Farzad notices this around March 7th. He's like watching these data like a hawk. So this is New York City subway ridership data. And the blue line is March the 4th. It's not a very straight line, but that's what it is, which is the day that the cluster of cases in New Rochelle was first identified. Nobody had died in New York City at that point, but there you are. By the next Monday, you can see that already the number of subway riders has dropped. So by the 10th of March, the 9th of March, whatever that is, it says Marcy, I didn't even notice that until now. Until by the 9th or 10th of March, you actually see a pretty substantial decline in subway ridership. By the 13th of March, I think that's what it says, there's been only one death in New York. So coronavirus, you know, we see these appalling pictures you will remember from Northern Italy, but nothing has really happened in New York. But look at what's happening to subway ridership. The city hasn't closed down yet, but a lot of people are already staying home. And by that Monday, when there had been 9 deaths in New York, subway ridership has just fallen off the map. Some of that is the shelter-in-place order. A lot of it is people just changing their behavior. And you can see that this is the New York Times has done this, looking at what happened to counties that did and did not shut down. And you can see that in counties that shut down, there was like an 85% reduction in travel. But even in counties that didn't shut down, there's a 65% reduction in travel. And I think it's notable. You can see on the top right here, the scale on this graph starts at negative 25%. Everybody in the country, even in places that were very distant from the epidemic, people were already responding to it. And going back to syndromic surveillance, you can see this. I think this is very interesting. First, look at the diagram on the bottom, which is the asthma count, how many people come into the hospital emergency rooms with asthma. You can see here that that doesn't really move until the 15th or 16th, and then it starts to fall, which I think is because air pollution drops as people are no longer driving in the city. But look at the diagram above, which is actually vomiting. I don't want to talk about why vomiting happens, but it's basically food poisoning, people going out partying, having too good of a time, eating street food, whatever. You can see that that actually starts to fall off much, much earlier than the city closes down. People are already taking precautions. And this is before we've seen the horrible deaths, the terrible efforts of, the difficult efforts of healthcare professionals to try and cope with this, opening the Javits Center, all of these things. This is well before that, and you already see all this response. So when we think about reopening the city, we want to think about prevalence elastic response. That is, people are going to respond based on what they think the dangers to themselves are. Let me close with some new analysis. This is actually the first project that we started to do after we heard about COVID, and it's a project with Mitchell, whom you heard from last week, looking at mass transit, because a big question here is to what extent New York City's mass transit system, the subway and so on, has played an important role in the spread of the disease. Now, we actually have no information on coronavirus because that won't be available for quite a long time, although it is striking that a lot of the epicenters, even in the New York area, are not necessarily people who are riding the subway a lot, but here's our pictures. We looked at influenza because most people think influenza is transmitted in a way quite similar to coronavirus. It's also a respiratory infection. And this is the population adjusted influenza death rate relative to transit ridership. What you can see here is that the death rate is not highly correlated with transit ridership at all. If anything, it's almost a negative correlation. Places with a lot of transit ridership don't seem to have a lot of influenza deaths. We repeated that analysis, controlling for a bunch of things, including influenza vaccination rates and other things like that, and it doesn't really change the picture. There's really no evidence in the data, and this is over many years, to suggest that this is, which I'm showing you 2015, but we have actually done this over many, many years, that there is an important correlation between mass transit ridership and influenza. So that seems really weird. I've shown this to people and they're like, yeah, but you get on the subway, people are sneezing, people are touching things, isn't that awful? And I had thought about it, and then I looked for a picture of what life is really like on the New York City subway. Look at that picture on the top, and you can see that what you're really seeing here is a bunch of people who are on their phones, who are not talking to anyone, kind of sitting there by themselves. A very, very different kind of atmosphere than, say, a bar scene, where people are shouting and talking and engaging with one another. So although people are in close proximity on the subway, they aren't in any sort of intimate proximity. And I think that may be part of the reason that we see that influenza result. It'll be interesting to see whether it holds up as we look at other diseases. So let me stop there and take your questions. Thank you.
Do you think the public option or universal healthcare will become more popular among the public due to coronavirus?
So I think that's a hope of many people who are in favor of the public option and universal healthcare. Unfortunately, I think one of the things that we're going to come out of this with is a lot of demands on public funding that will have to be met for many, many reasons. And that may actually slow the move towards a more aggressive health policy. If the economy is really in a shambles and we have a safety net in place as we do right now, I'm not sure that that is going to be sort of the first thing on people's minds. much depends on how long the coronavirus lockdown continues.
Is there a way to account for the out-of-pocket costs to patients with underlying pre-existing conditions that are exacerbated by coronavirus?
So we don't know the answer to that question yet. We will eventually know the answer to that question. I think that what we're going to see is a couple of, again, a kind of bifurcated story here. So one is, I think you are right that many of those cases, that $1,300 estimate of the hospitalization cost is for many people on top of many other costs that they will already have incurred in terms of out-of-pocket payments because they have underlying chronic conditions. So I think that's right in terms of thinking about the total out-of-pocket burden. You do want to think about those other conditions. At the same time, I think we've seen a big decline in the use of services. So that may offset a portion of those out-of-pocket costs for a very bad reason. It would be much, much better, I think, if people were getting those services and even if they were incurring the costs. So maybe in sort of responding to these two questions together, while I'm a little bit dubious about whether this is going to get us further towards the public option, I guess that kind of depends on what happens to Joe Biden in November. I can see this moving us towards a healthcare system that has a little bit less emphasis on out-of-pocket spending. We've really moved sort of to a crazy place there, and I think we might want to revisit our thinking about the importance of out-of-pocket costs and bring them down.
What do you think of Governor Cuomo's $2.5 billion Medicaid cut proposal? How will this impact people who will lose Medicaid coverage?
So I don't think the proposal will actually lead people to lose Medicaid coverage. It's a proposal that is basically going to cut coverage, is going to cut payment rates to providers. It is not actually going to change eligibility for Medicaid for the most part. The problem is that the state has a balanced budget rule and is supposed to do something with its Medicaid program. And somehow the governor is trying to operate in two different states of the world at the same time, the state of the world before coronavirus and the state of the world with coronavirus. I don't know how he's going to square that at the end of the day. A lot of money is going to have to go to the hospitals from somewhere. Some of this, I think, is jockeying with the federal government to see where that money is going to come from.
Should retired medical professionals be asked to provide pro bono services to the uninsured?
I think retired medical professionals may wish to provide pro bono services to the uninsured. I cannot see any world under which we would compel them to do so. But I will say, I think one of the more encouraging, from a public service standpoint, responses to the epidemic has been the tremendous interest of so many people to be helpful in whatever way they can. And some of those people are retired medical professionals. I certainly do not think that we want to be kind of drafting medical professionals to provide pro bono care to anybody, but that doesn't seem appropriate.
When you look globally at healthcare systems around the world, are there broader lessons? Did anyone get it more right?
So Canada, surprisingly, seems to have done better than the United States. They got testing in earlier. They were able to identify community transmission earlier. They went into lockdown when they had into shelter in place when they had fewer cases. And so they're doing a little bit better than we are, for example, and better than the European countries mostly are. Some of the European countries are doing a little better than others. Germany seems to be doing better. So I think there are some beacons. It doesn't really seem to have a whole lot to do with the structure of the healthcare system. I think it has a little bit more to do with maybe the efficiency of government more generally, the credibility of leadership in government. The Times today suggested women make better leaders in the time of coronavirus, and they had a story about the various women leaders who've done a good job. Maybe that's an argument.
To what extent are anticipated increased mental health needs and costs being anticipated? And if so, what approaches are being contemplated?
It's a great question. We've been talking a lot about mental health needs and costs and how those will be impacted by the epidemic. And I think you could divide those into sort of three categories. One is people with really serious emotional disorders, serious mental illnesses. They are in a terrible place right now because they need regular access to all kinds of care and services, including sometimes inpatient care, that is now dangerous, hard to access, and the providers who normally care for them are understandably very concerned about making sure that they have appropriate protection and so on. So that is one cluster of people. I would also put into that cluster people with ongoing substance use disorders. A second group of people are people with routine or less serious but still quite debilitating mental health problems. I think we've seen an explosion of telemental health, and I wonder how much of that will be retained after the epidemic is over. People are getting more care online, and there is the big issue there is making sure that we can pay providers for it, that we can appropriately monitor that people are actually getting services, that there's not fraud happening. But I think that is a direction we may continue to go. The third is people who are traumatized in one way or another by the pandemic itself, either because they've lost loved ones or because they're in shelter in place, young adults, so on. And there, I think New York City has a precedent in the enormous efforts we made post 9/11 to extend mental health services on a rapid basis to very large segments of the population. And that's a conversation that is happening right now about whether, for example, we want to have a helpline where people can get rapid access to mental health services and get triaged to more intensive services if they need them.
Given the media coverage on health disparities marginalized communities are experiencing due to COVID-19, do you think there'll be a more comprehensive policy response addressing structural inequities?
Well, I think that one of the things that is going to come out of this epidemic is much more thinking about why and how disparities emerge in our healthcare, in health in the United States. Where do those disparities come from, and what is the cause of them? How much of what we are seeing in terms of inequities in coronavirus cases, the actual extent of the inequities is a little hard to know right now because the data are so sporadic or spotty, but certainly there is lots of evidence to suggest that there are such disparities, some of them coming from underlying lack of access to appropriate care for people with chronic conditions, some of it coming from the social determinants of health, the way people are living, and then the needs of their, just to keep their homes together. They're living in more congested circumstances, they're overcrowded, they may have to go out on the street even when there's a shelter in place. They're the people who are providing, working in grocery stores, doing all of those essential services. So some of it will be that. I think I hope, perhaps, maybe better than think, that this will actually stimulate a much more committed response to the kinds of inequities that have long afflicted our healthcare system.
How do we get some of the healthcare coordination efforts to stick after the crisis?
That's going to be really hard. Here in New York, the hospitals have worked together across systems. They're normally tremendously competitive across systems. And we're not sure exactly, I think, whether we want them to be always working together. Sometimes you don't want all of your suppliers to be in league against the consumers. It's a good thing. And things that are a good idea in an epidemic are not always a good idea outside of an epidemic. We wouldn't necessarily want the governor to have as much control over our lives every day as we're willing to tolerate today. I think we really should think, so this is just a general policy rule here. There's a view that you should never let an opportunity go to waste, never let a crisis go to waste, that we're in this terrible crisis and therefore we should use it to move policy in directions that we want to move. I'm actually not so much of that view in this circumstance. I think sometimes a crisis is a crisis and you want to deal with it in the way that is best right now. And then when it's over, you want to think about what the best way to have a non-crisis health system, a non-crisis economy would be. Because trying to make the same policy in a crisis and not in a crisis might not be the right way to go.
If it isn't the subway, do you have any other theories as to what daily interactions are most contributing to the widespread transmission in New York State?
So I don't know, and I'm not an epidemiologist, so I'm a little nervous about making any arguments here. But part of this is communities that are, what what the pandemic has done is turned life upside down. We know that being in close communities is generally a very good thing for people's health. Being in faith communities, participating in clubs, social activities, all of those things, those are all good for people's health, except when there's a pandemic, when they are terrible for people's health. Living with your extended family is a wonderful thing when it's not a pandemic, and a terrible thing when it is a pandemic. So some of this is going to be about circumstances like that. It's also likely the case that we missed the boat because we were so focused on a virus coming from China, and the virus that attacked New York probably came from Italy. So it seems likely that it was heavily seeded in the New York area before cases even began to emerge.
Given the paucity of testing available in New York City and nationally, what strategies do you and other economists or epidemiologists use to estimate caseloads?
So I don't. I basically steal caseloads from other people because I am not an epidemiologist and I'm not sure how to do it. There are some methods people have used. One method that we know from back in the day of the HIV epidemic is called back calculation. So if you can get something that you feel a little bit more confident about, such as hospitalizations or deaths, you can kind of infer from that how many people might have been infected at various times in the past and kind of calibrate the numbers in that way. As you've probably seen, there have been a lot of deaths in New York that are not directly attributed to coronavirus, but probably are either caused by it or by people foregoing care for other conditions because of the existence of coronavirus. So even that is hard. Again, I think we are going to learn a lot more about this in the future. It's a little hard to make these analyses in real time, which is part of the reason that we were so focused on influenza, where we have 10 years of data going back.
Two-part question. What could have been done on March 7th when respiratory cases spiked dramatically according to the syndromic surveillance? Knowing that other countries were already struggling with the coronavirus, could medical experts looking at this data have made a case with the New York City or state government to act faster with restrictions on such a densely populated city where the risk is higher than most?
So I don't want to do Monday morning quarterbacking. It's really hard to do. But the reason those syndromic surveillance systems were put in place was so that people would be able to act sooner. And clearly it would have been an enormous dislocation and hard to actually successfully pull off a shelter-in-place order as early as March 7th. But perhaps that would have been the moment to start deploying testing in different communities in a different way. Again, I don't want to play Monday morning quarterback. I have no idea. But it is interesting if you look at the New York City data right now. It is really the syndromic surveillance system that they are counting on to be able to reopen the city, to be able to see what is happening to those visits and so forth. And so maybe not March 7th, but I think trying to think about how we use those systems that are not based on exactly this, not exactly testing for this, but trying to understand that something is going wrong, that might be the moment to do it. I think, you know, it's a very difficult time to be a policymaker. The costs of telling people to stay home in a place like New York are enormous.
What should be considered in the debates weighing the trade-offs between reactivating economic activities and the increase in cases it would convey?
So, as I said earlier, I think this is not going to be a decision that is entirely made by politicians. It's going to be a decision that is also made a lot by people. And even though there are people who are not going to be able to have much choice in the matter, if no one goes to restaurants and bars, no one is going to be employed in restaurants and bars. So this is not, there's a lot of agency. There are a lot of people who are going to make this happen or not happen. I think that in order for people to be willing to go about daily life, they are going to have to feel more protected than they do now. Maybe that will mean there are a lot more masks. Maybe that will mean that there will be more social distancing in restaurants and hotels, or in restaurants and bars. We are here, I guess, in a maybe a good position that Italy and Spain and some of the other European countries, which were first affected by the epidemic and first went on lockdown a week or two ahead of us, are going to come out of it, and we are going to learn from their experience.
What challenges will the healthcare system face in the second wave of infections, and what do you expect them to do better by then?
Um, so we don't know when the second wave of infections will happen or how it will happen. We don't know. There is so much uncertainty about the future. It is really, it is always really hard to predict the future. It is particularly hard in the case of a raging pandemic. We don't know what will happen to treatments. We don't know what will happen to testing. All of those things will matter a lot. A big question with the healthcare system is how rapidly can you switch gears? People have talked a lot about whether we should have had more protective equipment, ventilators, and so on in a stockpile. My own view is that that's not the right way to think about this. The right way to think about it is how quickly could you produce that if you needed it? And there's an example of, for example, what could you have done on March 7th? You might have been able to think about personal protective equipment and ventilators and things like that, even if you were not making the extremely costly decision to shut the city down. But hopefully, if there is a second wave, we will be better able to deploy healthcare workers. We'll be better able to control the pace at which cases enter the hospital. I think the toll that this has taken on healthcare workers and other essential workers is truly tragic. And that is something that everybody, I think, going into this knew was a possibility, and that we owe it to our fellow citizens to keep that from happening again.
COVID-19 nakedly exposed the weaknesses of the U.S. healthcare system, especially how it is slow, irresponsive, and expansive to deal with such a crisis. Do you think this crisis will provide an opportunity to revolutionize the healthcare system?
So the reason I don't think I mean, you can hear me expound on the flaws of the US healthcare system from here till eternity, but I don't actually think that the COVID crisis exposed those flaws particularly. We haven't done a whole lot worse than Italy or Spain or France or the United Kingdom with its National Health Service. Unfortunately, the structure of the healthcare system has not turned out to be the critical factor in any of those countries. It's more about public health and economic policy. For example, if we had better paid sick leave, more accessible unemployment insurance, if we had a better economic response, perhaps we would have been faster to trigger something like shelter in place. In fact, I think the irony of it is that everyone in Congress is so focused on fixing the problems of the healthcare system with respect to coronavirus, making sure that people don't have high out-of-pocket costs or they're not exposed to out-of-network, ridiculous out-of-network bills in the context of coronavirus. But after all, months before coronavirus, people were experiencing exactly the same terrible things, and people were not acting to help them. So, this has concentrated our minds and perhaps made us more generous towards one another, but I don't know if that will last.
Final question. What do you think will be the most important thing to understand when this is over for the public and for health policy professionals?
I think the most important thing to understand will be that nothing matters as much as how well your government functions and how much you trust it, and that having effective bureaucracies that understand data, can act on it, is actually the thing that saves all of our lives pretty routinely, and we should respect that. And we should all learn it at Wagner. So this is a great moment for us in that way. Thank you.